recorded also too for y'all. Okay. Let me make sure it's gone. Yes. All right. So GERD, like I said, it's just where that stomach acid is backing up. They'll have burning and pressure behind the sternum, mimics chest pain. So you have to rule out. You have to look at all your symptoms. What is happening is we have that sphincter between another sphincter. They're all over the place. You got your esophagus. That's the tube that the food goes down. And it hits your stomach, and there's a sphincter right there. And just like it controls the flow of urine on your bladder, this controls the acid from the stomach. And if it's weak or not working properly with sphincter, then that acid goes back up, and that's what causes that burning pain right here behind your breastplate, because it's acid and it's burning. And this is not supposed to have acid in it. Your esophagus doesn't have acid normally, so that's why it has the burning pain. And they'll, sometimes they'll say heartburn. Do you know the technical term for heartburn? I didn't know this. I had to look up and see what they were talking about in the book. Pyrosis. So if you see that, that just means heartburn. They'll also have a dry cough and hoarseness. Why do you think they have a dry cough and hoarseness? Hoarseness. It's that reflux of the acid. It's going up, and it even passes out of the GI tract and can get in your upper airway. So they'll have that hoarse, irritated voice, or a dry cough, because they're always trying to get that acid out, and a sore throat. They'll have difficulty swallowing. We know what's our medical term for that? Dysphagia. Good. And they'll have reflux is really bad after meals. Why do you think that is? More acid, and your belly's full. Instead of being empty, you've got it full of food, and so what's that do? That weak sphincter pushes it right on back up. So it's going to be worse after meals. Okay, so that might be a scenario question. Patient comes in, 45, complaining of mid-sternal chest pain or burning. Worse after eating. What should you think? GI. Because it's not going to be worse if it's cardiac after eating. That doesn't phase them. Alright, so think about that. If it's worse after meals, think about GI and start picking that question apart from a GI perspective. They'll have regurgitation sometimes, which this is awful. They feel that warm fluid coming up into the throat, a sour taste in their mouth from all that acid, and they belch a lot. So those are the symptoms they'll be telling you I'm having, and then you should think GI, GERD. Okay? Next one, y'all good on that slide? Does anybody have GERD in here? It's bad, isn't it? It's awful. That's down the road. We're going to talk about that. I got a slide for that. So then the medical management, here's if y'all are doing your farm questions and farm flashcards, these are your meds, okay? H2 receptors, this is for mild GERD. Those are like your Axid, Zantac, Pepcid, Tagamet. H2 receptors, let me just show y'all a cheat. H2 receptors, all in dynes. D-I, this thing is like ranidine. Yes, good. D-I-N-E. Those are H2 receptors. You see D-I-N-E, like I always think of dyne like dining or diner. That's an H2 receptor, and those are all for mild GERD. Okay. I have to word associate. So dining, eating, dine or anything that ends in dine, that's going to be H2 receptor for that GERD. Okay. It says Axid, Zantac, Pepcid, Tagamet. These are all in your book. If you're doing a flashcard, they have a good 2 pages, little cheat sheet, easy stuff to make those cards for. And yes, most of those are over the counter now. I think, except maybe is Tagamet over the counter? I don't think it's the only one. I think it's not. Can you buy it over the counter? Okay. So more severe GERD, though, if it's getting worse, they put them on a proton pump inhibitor. And those are called PPIs. Those are all in what? Y'all know? Zoles. Those are your Zoles. Z-O-L-E. So proton pump inhibitor. That's all. Proton pump is the one that pumps out all that acid in your stomach. And so this prevents that acid from being pumped out, these meds. And if you don't have as much acid, then you're not going to be as prone to regurgitate it. Okay? So that's like your Prilosec, Acifex, Prevacid. And I think most of those are over the counter too now. They're always on TV. then they might have something, an anti-ulcer medicine that is just kind of coats that ulcer, adheres to it, and smooths it over, and so that makes it less irritated and more prone to produce more acid. And that one is called Carafate, and I think they still use that in long-term care facilities. They give that a lot. Carafate, you might hear that or have given it before. It adheres to that ulcer, so it's an anti-ulcer med. Okay. And then if it's real severe, they can give Reglan, and you can give that one IV. They give that a lot in the hospital setting. Reglan, it increases the peristalsis, makes your bowels speed up faster, so that you have faster gastric emptying, and then you have less food in your stomach, so you have less reflux. And that's Reglan up there. Okay.
Isn't that the one that they also use to help with the med supply?
Reglan. Okay, and then Nissen, I don't even know how to say that. Fundoplication? Nissen? That is a surgical procedure that can strengthen that sphincter. So they go in, they tighten that up, almost like a cervical cerclage. That's what that one is. So those are the treatments, medical management they can do. If it's left untreated, it can cause precancerous changes down there. All that acid eats away at that, and that's what's called the Barrett's esophagus. Do y'all remember seeing that on your predictor or any of those tests y'all had to take? Barrett's esophagus. It's on where it leads to cancer of the esophagus, and they have to monitor it real close, 1 to 3 years. So if they have GERD, think Barrett's esophagus cancer. I want to prevent that, and we'll go into it more later. All right. So here's our nursing interventions. We know what the doctor's going to do. He's going to prescribe all those meds, but what do I need to do as a nurse for my patient? Got to start doing that education. We are teachers. We're not just nurses. We have to be teachers a lot. So you tell them you need to change your diet. So they will do a low acid, low caffeine diet. Tea or cola, coffee, that just makes it worse. That reflux worse because it's all acid. And instead of eating 3 big meals, they can eat 4 to 6 real small meals. That way the stomach's never full, and it helps lower that acid reflux. Nothing to eat 2 or 3 hours before bedtime, because when we lay flat, what happens? The acid just rolls right back out. And so they need to also keep their bed up high. Those are the people that you see cinder blocks or bricks in their house, their bed, they have the beds up, or they can use one of those foam wedges they make now. Low fat diet, high protein, and no alcohol. Nothing good. All of that just makes that acid worse, okay? So those are the things that, another one, it's on page 1414, but those are the things that they might ask you, how they like those diet questions. What would you tell your patient to avoid if they had GERD? Anything acidic, all the drinks like tea, alcohol, coffee, those are all going to make it worse, and keeping the head up so that acid stays down. If they smoke, they need to stop for all kind of reasons, but smoking actually triggers more acid production. That's why people, after they eat, want to go smoke so bad. Because their belly's so full and it feels so good. Because your belly's starting to produce more acid and empty. So if they already have bad problems with acid, do we want to make it worse? Try smoking? No. So we tell them to try to stop smoking. Tight clothes over the belly. We want to avoid that because it just seems like it constricts it and makes it worse. And then they don't want to work in a bent over position. Nothing like that. It makes it worse. And keep their head elevated, okay? Any questions on GERD? It's pretty straightforward. We're talking about, like I said, that if they keep that reflux, it just eats away at their esophagus, and they'll end up getting cancer. The squamous cell carcinoma, adenocarcinoma, all that builds up. So if they're an alcohol user, like bad, a lot of alcohol, chronic, or tobacco user, they have acid reflux and they're obese, that puts them at higher risk for that Barrett's esophagus. BARRETTS, Barrett's esophagus. If they have the Barrett's esophagus, then that leads to the cancer. Okay. same thing for nursing. You would want to prevent all that. Teach them low-fat diet. Teach them to stop smoking and using alcohol. Lose weight to help lessen that pressure on the belly. If they're having progressive dysphagia, like first they start out bulky foods bother them, like eating a big chunk of steak and it feels like it gets stuck right there, and then they get through that, and then a couple of even soft foods like pudding or rice, something real soft is difficult to swallow, and then a couple of weeks later they can't even get liquid down. That's progressive. And then if it's to the point where they can't even swallow their saliva, that's really bad. That's progressive dysphagia. So that is definitely a symptom that something's happening with that esophagus, and we need to get that looked at. They might have a chronic cough from all that acid. When they vomit, it's whole undigested food because it never even got to the stomach. It was stuck in their esophagus. So they'll vomit and it'll be food, like they just swallowed it. Again, they'll have hoarseness. They feel like food's stuck all the time right here. And then they'll have iron deficiency anemia. Why do you think they're going to have iron deficiency anemia? Not even getting to the belly to absorb, right? So they're going to be iron deficient. You'll see that when you do the blood work. And they'll have weight loss because, again, they're not getting any food into their belly. So it's not being absorbed and used. They'll have painful swallowing. Painful swallowing, though, is the late sign. If it's so painful for them to swallow, it's usually, that's an indicator of malignancy. It's spread to the liver and the lungs. Okay? So know those things, that's bad. If they're getting down to those, we need to go ahead and get some tests run, okay? And then in medical management, they'll do radiation, chemo, surgery. They can do the barium swallow, where they make them swallow that stuff to see where it's actually clogging or where it's going down or not. And then they can do some chemo. And then the surgery, they'll actually take out that section that might have the cancer if it hasn't spread too much. They can take that part of the esophagus out, resection. So GERD can get bad. Any questions on GERD? It's pretty straightforward. I think y'all probably have had, somebody or have had a patient because it's pretty common. Okay. Achalasia. It's also called cardiospasm. It's the inability of a muscle to relax, like that cardiac sphincter of the stomach, though. Okay. So the main number one symptom is dysphagia. They feel like they cannot swallow. They're having that substernal chest pain again, food stuck, and they might be regurgitating food. So it's all the same thing because we're only dealing with the same anatomy, right? A tube and a belly pouch. So symptoms are going to be very similar on a lot of this. They're going to give them medications, anticholinergics, nitrates, calcium channel blockers, all of those, just to help reduce the pressure on that esophageal sphincter. So they're going to dilate them. And that kind of helps to relax that so that it goes down into their belly. They think the cause of this might be like nerve degeneration, like people who've had a stroke and that nerve is not going to the belly or to the sphincter, and so that could be part of it. They may just have no peristalsis in their bowels, and so everything's backing up from the bowel to the belly, now to the esophagus. And this was really gross. I read this in the book. It said that they can hold up to 1 liter. That's like an IV fluid bag. 1 liter of fluid and food can be stuck in your esophagus. It just stretches out. I know. That's pretty amazing. That much. But they pulled out that as much as that. And this usually happens in younger people, 20 to 50-year-old, male or female. So that's pretty disturbing that you can be that young and have that much problems going on. Any questions on that one? I had never heard of that term. I've heard of cardiospasm, but I had never heard it called that. So I just put that in there in case y'all see that on your NCLEX. Now we're out of the esophagus. We'll go down into the stomach now, okay? these are real easy. Gastritis, peptic ulcer disease, and cancer of the stomach. These are all pretty straightforward too, okay? Gastritis, we know gast means stomach. Itis, inflammation, infection, irritation. So, irritation, inflammation of the stomach. The lining of the stomach. So this is real common in chronic alcoholics, smoking, and smokers, and stressful physical problems. So nursing school probably gave you gastritis. I think it did me. And just because you're always producing more acid when you're under stress, and so you're more prone to it. It just eats away the lining of your belly. Symptoms will be nausea, vomiting, sometimes fever if it's bad enough, diarrhea, headache, lost appetite. All that's just stress to me. That's normal. Yeah. So all those kind of things.
So, like, is that like whenever, you know, you get, like, sometimes I get, like, so stressed out, like, I feel sick to my stomach, not that I want to throw up or anything, but is that what it
Nausea?
is, like, no, not nauseous, just like, my stomach just, like, oh, it's just turning.
Could be nerves. But this is where the lining itself, you've been in that state for a long time, several months to years, and it will just eat away at the lining. So those are the symptoms they'll have, okay? Is it worse after you eat? You probably have an ulcer then. They say it's better if you have an ulcer and you eat it because the food absorbs the acid, so it stops burning if you eat. So that's what I tell this all the time, like it's before after you eat. Okay. So they'll come in and they'll tell you, like Christy, I'm burned all the time in my belly. Yes. You have to ask them. Anorexia means not skinny. It means lost appetite. Anorexia means they're not eating, lost appetite. Nausea, it hurts to eat. Maybe they just makes it worse. Pain, vomiting. Y'all know what this one is? Hematoemesis. What is emesis? And what is hema? Yeah. Blood in your vomit, in your emesis. And then melena. Y'all know what that one is? I had to look that one up too. I haven't used that term in a long time. Black tarry stools. So if they've got a bleed in their stomach, a little bit of that blood's going to go down through there, and that's why they'll have blood in their bowel movements. Okay, so melena. That might be a good term. Remember. Y'all good on that one? So, medical doctors will come in and they'll order a bunch of meds. They'll tell you to put down the NG tube, and we're going to lavage them. Gastric lavage, y'all remember that from level 1? Where you're flushing out the stomach, putting water and fluid in there to wash it out. If you put your NG tube down and you see coffee ground emesis, what does that mean? Coming back up out of that tube. Yeah. They have that looks like coffee ground, like when you take your old coffee grounds after you've made your pot of coffee. That's what it'll look like coming back out. It looks like dirt or coffee ground. That's old dry blood that's been sitting in well, not dry, but old blood turns dark, and it'll be sitting in their stomach. And as soon as you put that tube down and put them to suction, it'll all come out. And so that's what you'll see. I've got this going on. You might see coffee ground emesis. If it's bright red, then we know it's fresh blood, right? It's just started. But if it's dark, coffee ground, it's been doing that a while. So, you know our nursing interventions, always pick I-NO. That's always a good one to pick in case you're in doubt, because we always need to keep up with that. We're going to keep them NPO because we don't want to put more into a belly that's already feeling bad, right? So they stay NPO. They'll have their NG tube down. We're flushing, the lavage is where we're flushing water down their NG tube to wash out that stomach. And then the suction will suck it right back out. And then try to keep them away from anything that's irritating them. Tea, smoking, certain foods. And we're going to be giving them IV feedings instead. Because they still need nutrition, but we don't want to put anything in the GI tract, anything in the gut. So we can give them that TPN through their IV. So that they're still getting nourishment. Any questions on gastritis? There's some of the meds that they'll give, like antiemetics, things that keep you from throwing up. Compazine, promethazine. You know what promethazine is? It's real common. Phenergan. So the zines are antiemetics. They keep you from throwing up. So if y'all are working on your farm, don't y'all have a farm Skype today or something with Dr. Little? Okay. So promethazine, that's Phenergan. They give that a lot. They can give it IM or IV. Tagamet, Zantac, and then they might give them antibiotics just to cool that belly off. If it's already irritated and inflamed, they might give them IV antibiotics, okay? But nothing through the gut when you've got gastritis. You want to let it cool off. Okay. So, peptic ulcer disease. Guess what I have for y'all for peptic ulcer disease? You know I got a handout. So peptic ulcer disease is coming around. Well, that's coming around. I'm past these out. Everybody get a handout for the little guy, the gangster guy looking? Where are they? They're coming around. So this kind of covers a little bit all of it because, like I said, this is all real similar. So this will kind of help with all of these things we're talking about. But peptic ulcer disease, it's just ulcerations, ulcers, in the mucous membrane lining of the GI tract. They can be anywhere, right? Because mucous membrane starts here to here. You know that. But they most commonly occur in the stomach and the duodenum, which is your intestine. Okay? Small intestine. That's where you'll have a gastric ulcer if it's in the stomach, or a duodenal ulcer because it's in the duodenum. Pain is just, they'll say it hurts all the time. Pain. A dull, burning, aching pain. Gnawing. Just feels like it just never goes away. And where's yours located? Where's yours hurt? In your epigastric region? So we just diagnosed you, even though nurses don't diagnose. We know it in our head, we just can't say it out loud. We have to let the doctors think they're smart. So the number one cause of peptic ulcer disease, anybody know? What causes ulcers? Besides stress. Stress for sure. What is the bacteria? There's a bacteria. H. pylori. Anybody heard of that? H. pylori? It's a bacteria. It's pretty bad. If it gets in there, they used to give different kind of antibiotics. Now they can give, I think it's a Prevpac or something like that. It's got a little bit of everything in it. NSAIDs and antibiotics. And it just goes in there and kills the bacteria. Okay. Smoking makes it worse. Actually, NSAIDs make it worse. So excessive alcohol, stress, all that can make it worse. So every 3 days, the stomach lining will renew itself. But if this bacteria is in there, it makes it harder. It's just eating away at it. Okay. So H. pylori, remember that. H. pylori causes ulcers. So again, we're gonna do an NG tube. Anybody that's got a hot belly, you should know NG tube. Anybody that's complaining with bad pain in the stomach and they're throwing up and that kind of thing, always think NG tube. That's coming down the line. It'll be there. Okay, we want to cool that belly off. We're going to empty it so that we can see what's going on, give it time to rest, and then treat it. So NG tube, and you're always, as a nurse, you're going to be looking to see what comes out, right? Just like we look at the color and consistency of urine, you got to look at anything that comes out. Poop, urine, NG, secretions, everything. You got to look at it, what color, consistency, what does it smell like. We're going to be giving them antacids because, again, we want to decrease their acid production, right? So we're going to neutralize with antacids. H2 receptors, they block that acid secretion. Now, can I give an antacid and an H2 receptor together? They cancel each other out, don't they? So you have to wait about 2 hours. Because an antacid and a H2, they don't work together. This is all on page 1419 and 1420 if you want to do your farm flashcards. It's a real good list. It makes it real easy and simplifies it for all of this stuff because they do kind of run together. There's a lot of them, a lot of meds. Proton pump inhibitors, those are the Zols, remember? Where did I write it? Did I already erase it? There we are. Zols. They give those to help with secretion, inhibit the secretion of gastric acid in the stomach. And then they'll give them that same thing, that Carafate smooths over that, covers the ulcer so that the acid doesn't irritate it. And then they give them antibiotics for H. pylori. Do y'all know what the main one they give now for H. pylori? Flagyl. Flagyl. That's one of the else works. They'll try Flagyl and then Viaxin. I know, but I was just really surprised that we're down to Flagyl. That's her main concern. You can't drink a Flagyl. Yeah, it's bad. I mean, it's a real problem. Alright. So that may come up on your predictor. H. pylori, Flagyl. Alright, so our nursing interventions again, we're going to do our NG tube. We're going to be monitoring that. We want to know how much is coming out, what does it look like, what does it smell like, does it have coffee ground in it. Intermittent suction, we're not going to turn it on and leave it because we don't want that NG tube to get stuck to the side of the belly and make another ulcer, do we? So just intermittent suction, giving them the meds, assessing them frequently, and monitoring for vital signs. What would be our most important vital sign for an NG person? A person having gastric bleeding. Blood pressure, right? Because if they're bleeding internally, if they're losing a lot of blood, your blood pressure is going to bottom out. You're going to go in shock. So that's why we monitor vital signs closely for anybody who's having an NG bleed or GI bleed. Okay. Same kind of things. Eat smaller, frequent meals because we don't want to fill that belly up. Bland diet. We don't want to put anything spicy in there. No smoking and rest. So these are all the same. Alright, and then we'll do this one. Cancer of the stomach. This peaked, the book said this peaked in the 1930s, and I thought that was strange. I was trying to figure out why that would have peaked in the 1930s. I don't know, I guess because their bellies were empty, they were hungry because that was under depression on them. Was bleeding cause of death then? And it was higher in men. So I don't know if it's because they were alcoholics or they were not eating and everybody was depressed. I don't know. More commonly affected men, they're higher in Japan, China, Southern and Eastern Europe, South and Central America. I can see the Japanese having this because they're like workaholics. They never stop working. So maybe that's why they're stressed out or something. Maybe they have a high rate. I don't know. I'm sure it does. I'm sure there's a conspiracy theory in there somewhere. So anyway, that was just real interesting to me that I don't know why they have it more. I guess we're more laid back than we thought we were in America. They may be asymptomatic in the early stages, and then as it progresses, then they'll have the pale look, lethargic, and they're anemic. Same reasons, right? They're having a bleed, so they're going to be pale because they're losing blood. They're going to be anemic because they're losing blood. They're not eating and absorbing anything. And they're lethargic because they're not eating and absorbing anything. They don't have any fuel. So all that kind of ties in and makes sense, right? So they'll come in, and this is usually, like I said, little elderly, more vague epigastric discomfort, early satiety. They can eat 2 bites and they're like, oh, I'm full. Satiety means that feeling of fullness sensation. Weight loss. So you think, oh, well, they're just not eating and they're losing weight because of that. But then they start having blood in their stools, and they're vomiting after eating and drinking, and they're anemic. And we definitely need to know that we're going to zone in on something. Weight loss and blood usually go together with cancer. So they're having weight loss, blood and stools. We need to check for cancers. Yeah, no. All right, so then they'll have surgery sometimes to take that cancer out. They remove that part of the stomach that has the cancer, but that leads to a thing called dumping syndrome. Anybody have dumping syndrome? You want to admit to it? It isn't as bad as it sounds, but it's where they've taken out some of the stomach, and so now there's less room in the belly. So instead of having all this area, you've only got this much now, and so there's not enough room for it to digest, not enough time, so it just goes out of the belly faster. So it just dumps it out.
People have gastric bypasses.
Yes, that's exactly what happens. They get dumping syndrome because you've taken away half their belly.
So that happens, anybody that has a piece of their intestine removed has that?
No, this is for, they're having cancer of the stomach.
Oh, okay, only because I have a cousin that got shot in the stomach and they had to take out like 6 inches.
Yeah, I mean, it can happen too because there's less place for it to absorb, so it's less time. It's going to go through faster. But this one on the stomach is dumping syndrome usually. So if they've had gastric bypass or they've had stomach cancer, anything that's taken away part of their stomach, they're going to empty it out faster, okay? It also happens if you've had your gallbladder removed. If the gallbladder splatters and go brown, it's bad. Radiation, chemo, any kind of cancer. Okay. All right. And then for nursing interventions, we want to improve their nutritional status. We already know that they're not absorbing well because they only have half their stomach, right? So we want to give them a really nutritiously packed meal. More bang for their buck. Because if they're only going to be able to eat a little bit, I want to give them the most vitamins and nutrients I can in a small meal. So really help them with food choices and make sure that their diet that they're being served has what they need on it. Try to help them relieve their anxiety. That's a big word to have to hear when, cancer of any kind. So try to help them with that. Help them understand they're going to have tubes and how all that works. You're going to do a lot of teaching, and we're still monitoring their INO. And then if they're getting TPN until the incision heals and stuff, you're going to make sure that they're getting what they need. And then we're going to be doing daily weights and things like that, okay? Because we want to make sure they're not losing weight. Any questions on the stomach? Okay, let's take a break.
Thank you.
You're welcome. Go smoke. Increase your stomach acid production. Did you stop recording? Nope, it records even on breaks. I get to hear everything when I listen to it on YouTube. And I do know the difference. Y'all think I don't know, but I do. I know everything.
Those are the ones I need to copy. So.
Okay. Thank you.
Do you know everything?
I do. I heard everything that happens on break and saw everything that happens on break.
Do we get one of those packets with
Actually, how many points do I got?
125 questions?
It just says 10 too. That's it.
Everybody has
For
10.
the chapter,
Yeah, for today.
yes, she packed some.
Everybody.
This is pre though, right? Pre-assignment?
Oh, and post. So
She hasn't got
10.
post yet.
Did I get 10?
Last week.
But I wanted to know the total, you know?
What everybody got.
Are you sure I have 2 next week?
Look and see.
I see a 0 right there. And if it's me, I'm gonna be super mad.
Hold on.
There's the maternal one.
Can you, that's not 7 days. We don't have total.
This one's not done yet, or what?
That one's just the pre.
What's number?
Wait, I don't have anything right.
Oh, actually, you don't.
What the?
Did you turn it in?
Yeah, I turned it in. We're supposed to turn it in before today, right? Yeah, I turned it in last night.
I don't think that's right because I emailed her. She'll give you your points.
I'm about to email her right now.
what you were talking about, like the workbook stuff?
Okay, peeps. It's time for Cynthia and Marissa to go up one.
To go up one? I love it.
Desk and I need them all be cool.
What is it?
It's a cockroach. It's a fake.
Oh, you're touching it?
It's a fake one.
Oh. I was gonna say, why are you touching that?
I'm not gonna put it in a film.
Put it on the.
Check it out. It's a fake cockroach for Ariel and Christelle. Just put it in. Who puts out? Who do you think will put on this?
Are you gonna video it so I can see it?
I can.
Listen, I did this to Angela and everyone. She literally put her best. Like, it was so funny. Miss Wilson comes in. Okay, real quick. I just need to know.
I love their little words.
Who's screaming? What happened?
You didn't know Miss Wilson. She was that way.
What other thing?
I'm telling you, if you put a bug over by me, you're gonna see me.
I mean, Angela turned
can't
the
do
computer
bugs.
over. She nearly flipped the whole desk. It was so no, give it another page because it's so close.
How's your morning?
No, just did physical assessments. It takes forever. You going to eat too? You want to go to the plaza? The plaza?
Wait, what's going on at the plaza?
It's that new restaurant. We want to try it.
Oh, today at lunch?
No, tonight. Like at 6.
Yeah, I can be there. That's perfect.
Okay.
Because I gotta pick Carter up at 5.
Might have to change. I didn't.
Yeah, I don't want to go in this. Hey, Marissa Jewell.
I don't like to go any place that says instructor.
Yeah, I'm sure it's the instructor part that you don't want to show.
Yeah. I have this thing about wearing scrubs outside of work
I don't
anyway.
like it either. You're a target. You're a target.
I don't think anybody should wear scrubs outside of work.
Like my little friends that they were at the grocery store, and that lady was having a seizure, and she saw them and gravitated to them because she saw scrubs. People will see you
Housekeeping
and
wear scrubs, people.
they'll expect you to help them, and if you're like, I don't want to get involved.
And that's what my story is on housekeeper song.
Marissa, sign this for me. This was, I don't even know when you missed. When did
Oh,
you
I
miss?
have it. I have it done.
Here, just sign this and I'm going to I'm sorry, but I'm tired of these things.
I actually made up too much time. Me and Miss King had a real nice laugh about it.
What was this one for? What day?
It was last Friday.
So that would have been 45, occasional nursing, 10, and that was 8. That was Friday the 19th.
Or no, it wasn't. Hold on, let me look. It was the 12th.
And how much, you missed 2 hours? No, that was, I don't even know why I had you miss.
Okay, so this, I already did this, and remember I still owed you 30 minutes, but I
Yes.
did that 30 minutes the other day.
Do you know what,
Yeah.
so you had missed 3 hours, what you said.
Well, I had missed 2.5 because on Friday we only have you for 2.5.
Do you know how much you missed altogether?
Just that day.
Because I'm not keeping up with it.
I can go look. It's on that
I
thing.
mean, I just don't want you to go over, you know.
Yeah.
So when was this one that you missed? The extra 30 minutes.
No, it was that same day. This I already made up. Like, this is when I made it up.
So I'm saying you told me like you missed 2.5 hours. So where's your half?
It's in it's in that book. I'll have to go look.
I'll go get it for me real quick.
Yeah.
I gotta turn this in.
Well, can I wait? Just in case. If they see
yeah.
it, yeah.
You're gonna turn that around.
Did you give your wife your book? That was so sweet.
You're gonna turn that around.
What is she giving you? Is what I want to know.
It's a secret.
That's not for a class discussion.
TMI.
I have a question for you though.
What's that?
I don't know on everybody's. On mine, my capstone runs out today. There's nothing else on there. I can't
That's
get it.
everybody.
So how are we supposed to remediate what we just did?
Ask Nicole.
She'll send it to you. And then you have to do it
Did
today.
you just need one set of these? You have to do it today?
Today's the last day they, when they close it off.
So we have to put it for our remediation and we can submit it to her today.
I guess.
That's only if she sends it to us today.
She usually does that.
I'm gonna shut it down after today. How do you do
They
that?
just shut down the testing. I think we can still email her. Sure.
I don't know, it says we only have one more day and then it shuts out.
One more day of testing, right?
That's why I went ahead and printed out all my stuff. Before I go get back in. Huh? I printed it out. All those weekly tips. There's a lot of stuff. I had to run like a sack. Let's see if it gets on this.
She printed out our
I can't even see me. I'm so.
How the hell you read this shit?
I don't think it's right.
So it gives you the rationale on everything too.
She sure don't got ours on here. Devin.
You like your stuff you got? You like your book? Did you get the pharmacology cards?
Yeah, we both did.
You like them? I wanted to see what they were like. I wonder if they were good or not. Dang you, retarded. Huh?
I said I'll use them on the condition.
Oh, yeah. I was gonna say any kind of pharmacology that's quick and easy. That's all I'm about. I think I might have to teach pharmacology next level. I'm not looking forward to that. I might have to study just as hard because I haven't done all that in a while. Yeah. All right. Who are we missing? I'm gonna go ahead and pass these out for Miss Robertson. She had to. Admit one, it, for next week. Or do you maybe turn these in, or? Yeah, just turn them into me, and then as long as you've done it, and I give you credit for it, then you can have it back as a study guide. She just wants you to do it. Okay, did y'all get your admit ticket for next week? It's going around. Just we'll do that for next week. It's a good study review, and then I'll give it back to you after I check off, make sure everybody turned one in, and then we'll you'll have it as a study guide too. Okay.
We're taking a quiz tomorrow. We're doing a review. And, next Thursday, we're taking the test next Friday.
Tomorrow we have a reading quiz.
Right.
Then we'll finish up whatever lecture we don't have. And then next week we have more lecture, and we have a medication calculation test next week. Did y'all know that? It's on your syllabus for next week. And your ATI Med-Surg Proctor exam. So you don't have a reading quiz on your syllabus for that next week. Because you have a medication calculation test.
When's the next major test?
It's on your syllabus, week 9, unit 3 exam.
We take the proctor and we
It says ATI predictor. Yeah. And an exam. No, we can split that up. Whatever day y'all want to do the predictor, the other day we'll do your exam.
Allison's test next week.
So next week is Proctor and week 9. Have everybody passed their math already?
Not yet.
So what's next week? Next week is the Proctor, right?
Next week's a medical competency, and then Med-Surg, yeah.
And then when is our test?
And then class 9, yeah, week 9, is your unit 3 exam and your predictor. So that'll be a busy week.
So we gotta take a predictor on that Thursday because we gotta have it set
I mean, y'all know I don't mind splitting up and doing whatever. I want y'all to do well on all of it. So, okay. Are we ready, Miss Marissa? I guess we're ready. Okay. Any questions on the stomach? Because we're fixing to move into the colon now. It's pretty, I mean, like I said, it's all pretty much same. Nursing measures, signs and symptoms, all that. So it should be pretty easy. Do what? I'm not sure what page. We're in chapter 44. Okay, so the two things I want you to focus on for your bowel, inflammatory bowel diseases, are ulcerative colitis and Crohn's disease. These are real common. was like,
Okay, but we used to ran around them far.
It's a bug.
sorry.
We're just getting started, babe. Alright, well, let's get through.
So inflammatory bowel disease for ulcerative colitis. Anybody have this, or anybody in here know anybody had a patient? You do have it. What are your symptoms? So if you have this, you're going to have blood, mucus, and pus in your liquid stool. Yeah. So just like, how would you describe pus in the bowel movement?
How you spell it?
You're not going to spell it the way it sounds. Just like the urine. Make sure you put pus in stool noted, not pussy stool when you chart. Okay. Abdominal cramps, several stools per day. If it gets up to 15 to 20 stools per day, that's severe. They're gonna have to be hospitalized, okay? Because they're gonna get dehydrated. But this one is caused by the mucosa, the submucosal lining of the colon and rectum. It's just irritated. It's ulcered. So the blood gets in the pus because it's just eating away at the lining of the intestine. So that's why they have blood, and then it gets infected because you've got E. coli in your colon, right? So that's why you get the pus in your stools, okay? When they're having 15 to 20 stools a day, like I said, they're going to be dehydrated. But what are you losing when you're having that much? You're using blood, but yeah, somebody said it. Potassium, sodium, all of your electrolytes. Because it's shooting out through you. You're not having time to absorb it. And so not only are you going to be dehydrated fluid-wise, but you're going to be disoriented because now you don't have those electrolytes that kind of keep your brain chemistry in balance. So they'll have disorientation, confusion, dizziness, maybe an irregular heart rate now, on top of, having to run to the bathroom. So they'll give them, to diagnose it, they do a barium enema to wash it out, and then they inject that dye into the bowel itself with an enema, and then they x-ray them to see where it's actually ulcerated. The dye will stick to where the ulcer is. Okay? They'll have rectal bleeding, abdominal cramps, weight loss, fever. Why are they having fever? Yep, infection. There's pus down there, and it's irritated. There's an infection from that E. coli, and it's spreading through their bowel. And then they have tachycardia. Why do they have tachycardia? They're losing fluid. Good. They're losing blood. And what did we say when we're losing volume? Our blood pressure drops and our heart rate goes up because you're going into shock. Okay? So that's why they're having tachycardia. Good. On that one. So the medical management would be, they're going to give them the inflammatory response modifiers. That's like steroids. That's to relieve the symptoms of colitis. Remember, itis, we have itis there, so we have inflammation. So steroids, we know, go in and decrease that inflammation, help cool that bowel off. And then they're going to give them antibiotics because, again, this got E. coli in there. We normally have normal, bacteria. It's normal flora in our colon. But in this case, it's flared up, so they're going to give them some antibiotics to cool that colon off. And then immune response modifiers, those are also like steroids. And then antidiarrheals, Imodium AD. It's also called loperamide. Have y'all given that one before? It's over the counter. Now, in this one, colitis, you do give them antidiarrheals, okay? Later on down the road when we talk about the other stuff, when they have a bad infection, you don't want to give them antidiarrheals. You want that to get out of their system. But in this case, this is just their normal flora that has just irritated the colon wall. So we give them antidiarrheals to slow them down because remember, they're going into shock. They're losing too much fluid and electrolytes. So we want to give them antidiarrheals on this particular thing. We want to make sure that they're getting plenty of nutrition, so they may get the TPN. We want to make sure they're replacing what they've lost through that excessive diarrhea. And then they may even have to do some kind of surgical control where they go in and section out the part that's severely ulcerated. Otherwise, this just keeps continuing. Okay, all your nursing assessments, pretty much the same thing. We're going to watch the elimination pattern. I know. Check it every time. We're going to assess and treat their pain, because this is painful. They're cramping. And then we want to watch their nutritional status. Are they hydrated? Are they getting what they need? Are they confused because their potassium's too low? So we're going to watch for that. And then coping abilities. This is difficult for anybody that's able to walk around and stuff and get to the bathroom. But what if you were having trouble ambulating and you're having to go all the time and having accidents? It just wears them out. And it's embarrassing for them. So help them, reassure them, and then you're going to educate them and tell them what's happening and that this is not, we're going to get this under control so that it calms them down some. And if you're doing pre-op measures and post-op care, we're going to watch I-know. Same things. We're going to watch for bleeding. We're going to watch vital signs because we don't want anything to be out of whack and we didn't report it, do we? Okay. I'll get on that one. Crohn's disease. This is the other one of the colon, okay? Both of these you want to avoid stress, and the longer that they have these in their colon, these issues, that's higher risk for cancer, colon cancer, okay? So know that we want to get that under control. Now, Crohn's disease, I got you a handout.
I got a whole folder.
I know, and you're going to love it. Somebody sent me a picture from Clinical the other day of a handout that I had given to them. Have you been here? Maybe. So this is Crohn's disease. It's a little lady on the toilet, or a man, I guess it is a lady, and we'll talk about what it is, but this will help you remember a lot of this intestinal things, okay? This is in the GI tract and along, but mainly it's usually in the colon, okay? In the ileum and in the colon, but it can be anywhere on the GI tract, but it usually develops in the colon. So Crohn's disease, colon. The cause is not known. They think it might be genetics and environmental things, stress or eating, maybe the water system that they're on, just something in their environment that's irritating them. A lot of times they've linked it genetically, but could be immune response. We have people that have lupus and all those autoimmune issues. They usually have Crohn's disease too. So they're still doing a lot of research on it. It's usually in adolescence and early adulthood, though. It's not in elderly people. It's usually in younger people. It's where the mucosa, that mucosal lining of the intestine, is not doing what it should be. It's not absorbing, and they'll have a cobblestone appearance. So when they go in to do a scope, they can see it, and it looks just like a cobblestone street. Do y'all know what a cobblestone is? It's just all patchy, where it's just eroded and scarred over, so it just ends up having this weird pattern, and that's the telltale thing of Crohn's disease when they see that. Malabsorption, like I said, is a major issue because they've scarred over. Their whole intestine, which is where you absorb all your nutrients and stuff, has scarred over, so there is no absorption of any vitamins or nutrients, and so they will be emaciated or not. When you do a blood work on them, they're not healthy. They could have obstruction, bowel obstructions, and abscesses just because of all the scarring and rescarring. So nutrition is a big deal, right? Your nursing diagnosis for this one, altered level of nutrition, that'd be something to really worry about on all of this, really, on all GI. All right, so they'll signs and symptoms, they'll have diarrhea, fatigue, abdominal pain, weight loss, fever, malnutrition. Same things as the others because, we're on the GI tract. All to do with food and nutrient absorption. So if you're not absorbing, you're going to be tired, you're going to lose weight, you're going to be malnourished. So these are all very similar symptoms. Weakness, lost appetite, abdominal cramps, pain, frequent BMs and diarrhea, and then they might even have a fistula develop. Do y'all know what a fistula is? A little hole that develops between the colon and the JJ or another area. It can develop anywhere in the body, but they'll have a fistula, and so they'll have stool coming out of another area that it's not supposed to come out of. Yeah. No, not a good one. Medical management, again, same things. Anti-inflammatory, want to cool that gut off. Steroids, they're going to give them vitamins because they're not getting enough of what they need, so they'll try to give it to them, and it's absorbed in the stomach rather than in the colon. The vitamin will be absorbed there. Give them some kind of immunosuppressive therapy, low-dose radiation, or either some kind of low-dose chemo pill, and that helps get rid of some of that where your body's fighting itself syndrome. And, of course, dietary modifications, you're going to teach, and work on getting them to eat the most bang for their buck so they get the most nutrients. And sometimes they have to do surgery on them, too, and just repair that area or take out that area that's so bad it's causing all the problems. With Crohn's disease, the other telltale thing is they'll have right lower quadrant abdominal pain. Classic sign. What else is in your right lower quadrant? Appendix. So this is going to be the same thing. They rule that out, make sure it's not their appendix, and then that's how usually they get diagnosed with Crohn's, because they've ruled out, they keep coming in with lower right quadrant pain, but they don't have the blood work to show that it's appendicitis, and so then they find out they have Crohn's disease.
Is that how they diagnose appendicitis with blood work?
That and rebound tenderness. They also have steatorrhea. Y'all know what steatorrhea is? Yes, fatty stools. Let's spell it for you.
So it's fat in the stool?
Yes.
Like, what affects that from the stomach?
It's not absorbed, so it's shooting right through you. You'll see that term on people who have no gallbladder too, because the gallbladder stores bile. The bile is what breaks down the fat. So if you don't have a gallbladder, you have fatty stool because it's just shooting right through you.
Which means you're losing weight though, right?
You're not absorbing as much.
You may need that.
That's why people who have had, sorry, I spelled that wrong.
They need a lot of
Had their gallbladder out, they can't eat fatty fried foods because it shoots right through them. They have the gallbladder splatters. That's what it's called.
Can they hold it and then push it down?
No, it shoots through them. It's hard to control. It's just like real, loose stool. Fatty stools, steatorrhea. You see that term again, you'll know that's what it means, okay? Any of this, they can have it because they're not absorbing, right? Okay. One more handout. This is on peritonitis. This is good for kind of all of this, but I actually had a friend called me last night from another state. Father-in-law had been in a car wreck yesterday morning. That afternoon, they'd seen him home, no big deal. He came back, his belly was hurting, running fever, blood pressure was down. I was like, he's got peritonitis. He had ruptured, when he got hit on that side, his bowel ruptured. And all that E. coli and stuff in his colon was now in his abdominal cavity. So 10 to 12 hours later, he was showing signs of peritonitis. They did a CT, and guess who was right? You. So now he's in the hospital getting antibiotics. But anyway, so that's a good thing to have in case they ask you questions on it for the NCLEX. Did y'all get this slide? Oops. It's tomorrow. Okay, so also I forgot to tell you on Crohn's disease, this is kind of similar to, remember we said a while ago, they're going to be iron deficient because they're not getting their iron absorbed. They'll give them iron injections, and they can also give B12 injections. So, because they're needing that. We want to give them high protein and high foods and water. We don't want to give them a lot of roughage, like broccoli and things like that, because that's going to make them have more gas and no caffeine or anything like that. We don't want to push through, irritate their already irritated colon. Okay. Any questions on Crohn's? Did y'all look at your little lady on the handout? She looks pitiful. Okay. So when we get back from lunch, we'll come back at 12:30, and we'll do some other stuff on this. I need, though, before y'all leave, I need to see a couple people. I need Cynthia. I need Consuela. You. Stephanie. I need Marissa. I need Angela. Cynthia Ragosa, and then I need Marissa. I need your time too. Do I have your time already? I thought you were saying.